Good morning, everybody. Happy Tuesday morning. Welcome to PCH Grand Rounds. It's my honor to introduce our speaker this morning, Dr. Carrie Schaefer. Dr. Schaefer is a native of Michigan, and she is a Spartan through and through. She did her undergrad, medical school, and residency at Michigan State University. She then went on to do a fellowship in pediatric radiology in Houston at Texas Children's, and she has been here at Phoenix Children's ever since, at least in Phoenix ever since. She is currently in our Department of Radiology as a pediatric interventional radiologist. Her topic this morning is central venous axis and anatomy. So please welcome Dr. Schaefer.
Good morning, everyone, and thanks for being here. So today we're going to focus on central venous anatomy and central venous access and the complications related to tip position and ways to handle those, as well, and recommendations for ideal catheter tip position. I want to review the anatomy first, and we're focusing on the upper extremity. And on this diagram, what is important to know is that there are two brachial veins, a single basilic vein typically. The brachial veins join, and then the basilic vein joins with the brachial vein, and then from there that forms the axillary vein. Once the vein crosses medial to the lateral cortex of the first rib is called the subclavian vein, and then from there the subclavian vein and internal jugular veins join on the right to form the right brachiocephalic vein, which has a vertical orientation, and then on the left to form the left brachiocephalic vein, which typically is either oblique in orientation, like you see here, or it can be somewhat transverse, somewhat vertical, but it's usually oblique in orientation. And then from there, the brachiocephalic veins join to form the superior vena cava, and then the superior vena cava goes into the right atrium, into a large chamber. Same with the IVC entering the right atrium. So this is just a drawing of the anatomy. And on this chest x-ray, there's an overlay of the vascular anatomy of the mediastinum. So here you can see the left brachiocephalic vein oriented obliquely, the right oriented vertically, and then the right lateral margin of the mediastinum is formed by the superior vena cava in older children. And then the right heart contour is formed by the right atrium, and the left cardiac contour by the left ventricle. And here's another drawing. So this helps when you look at chest films to look at catheter tip position, so it gives you an idea of what you're actually looking at. So again, the brachiocephalic veins join to form the superior vena cava, and then down into the right atrium. And the right atrial appendage is actually anterior to the superior vena cava, and it extends above what's known as the caval atrial junction. These are coronal images from a CT showing the anatomy, and we're going from anterior to posterior. And what you see here is a pacification of the left brachiocephalic vein, the right brachiocephalic vein joining to form the SVC, extending into the right atrium, and then IVC. Here's a 3D rendering of the cardiac anatomy and great vessels. And from the frontal view, this is the right atrial appendage, and this extends above the junction of the superior vena cava and the right atrium. And from a right lateral projection, this is the superior vena cava. Here's the right atrial appendage. So this anatomy comes into play for catheter tip position and complications. So the question is, what is ideal catheter tip position? And there has been discussion over the years about this and many research projects, and I'm going to go over some of those. But there have been reported complications of high catheter tip position and low catheter tip position. So complications described with the catheter tip in the right atrium or near the right atrium include cardiac perforation. You can have tamponade, you can have cardiac dysrhythmias, and you can form thrombus in the right atrium. For high tip position, meaning higher in the superior vena cava or even into the brachiocephalic vein, complications include thrombus of the superior vena cava, and brachiocephalic veins, as well as veins above that level. You can have catheter dysfunction, which includes catheter clotting. It causes also fibrin sheath formation. And you can have perforation of veins, including the superior vena cava and the brachiocephalic veins. If you do, you can get a cardiac tamponade. You can also get hemothorax from blood dissecting into the pleural space. The other risk is catheter tip migration. So if you have a line placed from the left and it's short, let's say the tip is in the upper SVC, that catheter can flip up into the right brachiocephalic vein and cause thrombus, as well as result in fibrin sheath formation. There have been recommendations over the years for ideal catheter tip position. Going back to 1995, the FDA recommended that the catheter tip should not migrate into the heart. And that was pretty generic. The National Association of Vascular Access in 1998 recommended that the catheter tip should be in the lower third of the superior vena cava. And if that's the case, that means that the catheter has a nice straight course in the lower SVC. There are dokey guidelines, which is with the National Kidney Foundation and the Kidney Disease Outcomes Quality Initiative for HD catheters. And the recommendation is that the hemodialysis catheter tip should be in the mid-right atrium. This allows for the best flow rates through the hemodialysis catheter. The dokey guidelines were updated in 2006 and in 2015. And in 2006, there were specifications for hemodialysis catheters in pediatrics. And one of the recommendations is that the internal jugular vein is preferred for access over the subclavian vein. And there have been reports of greater than 80% of patients who've had, pediatric patients who have HD catheters placed in the subclavian vein, over 80% have had subclavian vein stenosis. So this is by the recommendation for internal jugular access for HD catheters. And then femoral access is utilized when the upper anatomy veins are not available. And again, the catheter tip should be in the right atrium, so it's usually mid to deep right atrium for HD lines. There are also some guidelines for hemodialysis catheter size from dokey, and this is variable. What you do is you place the smallest catheter that will allow for the flow rates that you need. So it's not always dependent on patient size. It is what the catheter is being used for, whether it's hemodialysis, apheresis, etc. So we are under the understanding in general that the ideal tip position is at the caval atrial junction. So the question is, where is the caval atrial junction? Baskin et al. Did a study in 2008, a retrospective review of chest CTs to identify the true caval atrial junction based on embryology and then applying that to the anatomy. And this included young adults and adolescents. So here is a drawing of the right atrium and great vessels, and you see that the superior vena cava, it descends into the right atrium and is bordered anteriorly by the crista terminalis in the right atrium and posteriorly by the crista dividends. So you can see just from this rendering that it's not a true transverse orientation of the caval atrial junction, it's oriented obliquely. So knowing the embryology, this was applied to the anatomy on CT. And what you see here is for the superior vena cava at the junction with the right atrium, that the actual junction anteriorly is a little bit higher than the junction posteriorly. And the SVC is simply a tube that goes into a hollow chamber. So it's actually inside the right atrium. This is a scout from a CT. And to look at landmarks in relation to the caval atrial junction, which would be reliable, you look at the middle mediastinum, because the superior vena cava is in the middle mediastinum. So because of that, they utilize the carina as a landmark to identify the caval atrial junction. And in reviewing all these CTs, what they discovered is that the true caval atrial junction is 2 vertebral body units below the carina. So the vertebral body unit includes vertebral body and intervertebral disc space. So when you look at this rendering, you see that the carina is at the superior end plate of this vertebral body. So going down 2 vertebral body units, it places the caval-atrial junction at this level. In the past, people thought that the caval-atrial junction was where the right mainstem bronchus crosses the right heart margin. So we know that's not true. It's much lower than was believed. So when you're placing central lines, other than HD catheters, the goal is to get it at the caval-atrial junction or in the lower third of the superior vena cava where the catheter has a nice straight course. The other thing that was noted is that superior vena cava length varies with patient height, but typically the superior vena cava starts 2 to 3 centimeters above the level of the carina. So here in IR at PCH, we're using caval-atrial junction as ideal tip position, except for HD catheters, where we get those into the mid-right atrium. And what we're doing is utilizing 2 vertebral body units for caval-atrial junction in bigger kids, and then for smaller ones, infants, toddlers, it's about 1.5 vertebral body units below the carina. And as long as you're in the lower third of the SVC where you have a nice straight course of the catheter, the complication risk is lower. The other thing to really know is that catheter tip position is very dynamic, especially with PICC lines and ports. So with the PICC line, if it's placed in the right arm, when the arm is brought down to the side, when it's adducted, the catheter tip is going to be in its deepest position. So when we're placing a line, that's typically how we position the arm to confirm tip position. When the arm is abducted, meaning brought away from the body, the catheter tip tends to go higher. There's more motion with right upper extremity PICCs than with left upper extremity PICCs. The other thing is with ports, if you have an obese patient or a patient with large breasts, when they're upright, the actual device goes lower on the chest wall, so the catheter tip will migrate higher. So you have to think about that when you're placing the line. Some of the complications, again, with abnormally positioned central venous catheters include venous thrombosis and also catheter dysfunction. So you can have clot in the catheter, you can have fibrin sheath formation, you can have thrombus at the tip of the catheter. Some of these things happen when lines are well positioned as well because of hypercoagulable states of the patients. If they're oncology patients, typically they're at risk for thrombus formation. Some of the complications with immediate catheter placement include pneumothorax, hemothorax, and air embolus. And there are also delayed complications from line placement, and that includes occlusion or stenosis of the veins. You can have catheter pinch-off or fracture with lines that are placed into the subclavian vein. And then also you can have intravascular foreign body if there's fracture of the catheter. There was a study by Carrie et al. In 2005 where they simply looked at central venous catheters and the complications related to tip position. And this was for implantable port catheters. And they identified the catheter tip position based on brachiocephalic vein in the SVC, whether it's upper, mid, or lower third, and then also they had right atrium or IVC location. And the rate of thrombosis is much higher when the catheter tip is in the brachiocephalic vein or in the upper third of the superior vena cava versus in the middle third or lower third. And then there were complications related to right atrium and IVC. But when you see with the catheter tip in the lower third of the SVC, the rate of thrombosis was 1.5%, and they had no catheter dysfunction in this study. So again, ideally, lower third of the superior vena cava or caval-atrial junction for catheter tip. So really the take-home message is a short catheter has many more complications than a well-positioned catheter. There was another study by Engstrom et al. And in this one, they were looking at hemodialysis catheter tip position and also whether it was placed in the right internal jugular vein or left internal jugular vein. And what they found is that when there was a catheter placed in the left internal jugular vein that was short, meaning that the tip of the catheter was in the SVC or near the cable atrial junction, which is too high for an HD line, that there were more episodes of infection and catheter dysfunction than those placed from the right internal jugular vein. And then also, when an HD line was placed in the left internal jugular vein, if the catheter was short, again, in the SVC or near the cable atrial junction versus well-positioned in the mid to deep right atrium, those catheters had more episodes of dysfunction and infection. And then placed from the right IJ, if the catheter tip was high, meaning again SVC or cable atrial junction versus well-positioned in the mid to deep right atrium, the incidence of catheter dysfunction and infection, there was no change. And I think it's because of the anatomy, with the right IJ going to right brachiocephalic having a nice vertical course, that when the catheter is short, it's still vertically oriented in the SVC. Whereas on the left, when the catheter is short or pulled back, then the tip of the catheter is abutting the right lateral wall of the SVC. When it happens, you have repeated injury to the endothelium of the SVC, and you form thrombus in the SVC or around the catheter tip. Here's another study by Peterson et al. Looking at catheter tip position and the rate of complication. And what you see again is that there's an 87% incidence of complications when the catheter tip was in a brachiocephalic vein, 32% in the upper SVC, and then when you go lower into the SVC, the complication rate is much lower. So again, it just brings home catheter tip position. Yes.
Could I have some bread?
Of the catheter itself? I don't have that on this study, but I'm going to go over some examples to reduce complications related to catheter size and vessel size. SIR has guidelines for central venous access, and again, indications for central venous access and complications and success rates. So some of the indications for central venous access include chemotherapy, continuous infusions, difficult IV access, and then plasmapheresis, hemodialysis.
She's working on her makeup.
And then for success at accessing veins, it's very high using imaging guidance. So when we place lines, we use real-time ultrasound guidance. So we're watching as the needle or the angiocatheter goes into the vein to reduce the risk of complications from accessing, including pneumothorax, hemothorax. And then the complications are categorized as to whether they are major or minor complications from line placement. So major complications typically require hospitalization. It requires a change in the patient's management, and you can have permanent consequences as well with these complications. So the complication rate is very, very small using real-time guidance for venous access. You're all probably aware of the different catheters that we place. There's option for PICC lines, for temporary central venous catheters, hemodialysis catheters, implantable ports, and tunneled cuffed or non-cuffed lines. Here's an example of a line placed from the left upper extremity with the catheter tip of the cable atrial junction. When you look at the carina, which is at this level, if you go 2 vertebral body units below, you're at the catheter tip. So this is ideal tip position. And again, we got this with the arm down by the side because the catheter tip would be in its deepest position with the arm in that location. At PCH, we have a vascular access device algorithm, and it's actually embedded in the venous access order on the top right. But to help select the appropriate device, you first look at what is infusing into the patient. So are you giving an irritant or a vesicant or not? If you are giving an irritant or a vesicant and you need access for 7 days or less, then good choices are a PICC line, a temporary line, or a non-cuffed tunnel central venous catheter. If you need access for more than 7 days, then still a PICC is an option and a non-cuffed tunnel central venous catheter, but also you could consider a cuffed tunnel central venous catheter, the Broviac line, or an implantable port. If you are not giving an irritant or investigant and you need access for less than 7 days, you can go with the peripheral IV. If they don't have access, then you'd go on to other central access. So again, you can use this in the venous access order to help determine what catheter is best for the patient. And then also, depending upon what's infusing, if you're doing TPN and lipids, then we'd place a dual lumen line so that you have one line available for other infusions and blood draws. Here's just some pictures of the devices. So here's a PICC line. This is a power PICC, a dual lumen. And the power lumen will always be purple. And this is just a standard PICC. So it's white. Here's an example of a tunneled cuff central venous catheter, which has a cuff on the catheter, and the subcutaneous tissues become embedded to this cuff, typically about 2 weeks after placement. So when you place a tunneled cuff line, they can be pulled out initially. We typically suture them in, but they can be pulled out until there is adherence of the soft tissue to the cuff. So the advantages of the cuff are that this is a long-term catheter. One, it's a physical barrier to infection with the cuff, but also it's used for continuous infusion. So if a patient needs TPN continuously, this would be a good choice for the catheter. You just need something you can access continuously. Or if it's chemotherapy, for instance, and they're going to have access multiple times in a week, this is a good choice. An implantable port is used when you need less frequent access. It could be weekly, it could be monthly, but you still need long-term access or they have difficult venous access. So this is used for patients getting chemotherapy and then occasional infusions. And here's an example of a hemodialysis catheter, and there are two different forms. One is the ash split, where you have one longer lumen and then a shorter lumen, and there are other catheters where the lumens terminate at the same level. And then this chest x-ray, you can see that the catheter tip is deep in the right atrium. And this would be where the cuff is. So for HD lines, we also have temporary HD catheters, which are placed in the internal jugular vein typically. There is no cuff, they're sutured in, and it's for access 7 days or less. So again, ideal tip position for central lines is 2 vertebral body units below the carina. Unless it's a smaller child, then we'll go 1.5. But as long as you have a nice straight course of the distal catheter in the lower third of the SVC, you're good. Here's an example where you have a short line from the left. So this catheter tip would be abutting the right lateral wall of the superior vena cava every time there's cardiac contraction, again risking thrombus formation, whereas the line placed from the right is 2 vertebral body units below the carina. So it has a nice straight course, so the risk of complications from this line is low. For access routes, there's internal jugular vein, there's basilic, brachiocephalic as well. You can do common femoral vein. We've done femoral veins. And also you can do more esoteric routes, which I'll go over. But we typically avoid the subclavian vein because of the higher incidence of stenosis and occlusion, both symptomatic and asymptomatic. When patients have limited central venous access, you can actually go directly into the liver with a catheter entering a hepatic vein, and then the catheter tip would be at the junction with the right atrium and the inferior vena cava. Also, you can go directly into the IVC using a translumbar approach. The benefit of using a transhepatic approach is that when you take the catheter out, you embolize the tract in the liver tissue. So it makes it less likely for blood to leak out. When you do a translumbar approach, there will be some leakage of blood from the IVC, which stops quickly because it's venous. So our whole goal for venous access is to conserve veins for a child's future. So to do that, we use the smallest diameter catheter necessary for that patient. We use the fewest number of lumens. Typically, dual lumen catheters are larger than single lumen. However, there are some new catheters coming out, the 3 French dual lumen, for instance, which we'll be able to use in the near future. So that's kind of taking that issue away where we can go smaller. The problem is that if you need a power injectable catheter, the rates are not always as high, but again, there's a new line coming out where you can power inject smaller diameter catheters. So we will be using those in the near future. Another way to think about venous conservation is to assess, does the patient still need this central line? So if you think about that daily or monthly, if it's a hem-onc patient, whatever it is, but you really need to think about when is that line no longer needed. And then when it's not needed, take that line out. And the goal is to choose a catheter that fills less than 50% of the vein lumen. It's not always possible in our NICU babies and smaller kids, but that would be a goal for venous conservation. And then, most importantly, get the catheter tip in ideal position. So when the line's pulled back, it's really important that we repeat a chest film, or if it's placed from below, a KUB to see where that line tip is, because when those lines are short, that's when you're going to have complications. So for central venous access, we use imaging guidance. We use ultrasound to get into the vein, real-time guidance, and then from there we use fluoroscopy as we advance catheters and wires into position. I just wanted to show you some examples of central venous access with malpositioned lines. And another thing to think about is sometimes when ports are placed, the kids are small, or even a Broviac type catheter, they're small, and these kids grow. We haven't been doing surveillance to look at catheter tip when kids are growing, but I think that's something we should think about doing, because as these kids grow, the catheter tip is going to be higher in position, predisposing them to complications. So here's an example of implantable port catheter, right subclavian access. The catheter tip is about mid-SVC, but it's going toward the medial wall of the superior vena cava. 3 years later, PICC line was requested, and the vascular access team nurse attempted PICC placement. But what happened is that the catheter looped back upon itself at the level of the lateral subclavian vein, and then the catheter tip extended cephalad toward the cephalic vein. We did a right upper extremity venogram, and the right subclavian vein and brachiocephalic vein are completely occluded. Here's an example of a kid that had a non-functional hemodialysis catheter. So this line was pulled back. The catheter tip is at the level of the azygos arch, high in the SVC. So you can imagine that this is continuously hitting the right lateral wall of the superior vena cava or into the azygos, risking thrombus formation. So this catheter tip should be about right here. So it's way high. We did a venogram, and on the same child, there's complete occlusion of the superior vena cava. These are all collateral venous channels that are around the superior vena cava. And there are also numerous collaterals around the left brachiocephalic vein. Another example, a kiddo that had a left subclavian port, and the catheter is short. So my guess is this child grew quite a bit. And then once they had complications, there was a chest film performed showing malpositioning of the catheter. And the catheter tip is at the junction of left brachiocephalic vein and superior vena cava. We did venography. An injection through the catheter shows acute thrombus in the right subclavian vein. So you can see this filling defect in the right subclavian vein with contrast around it. And then also there are numerous collaterals in the upper mediastinum and in the right neck. And from the right upper extremity venogram, you can see, again, collaterals with occlusion of the right subclavian vein, and the brachiocephalic is gone as well. So for this child, what we're able to do is get access through the right upper extremity, and then also the right internal jugular vein here. We did balloon angioplasty of the superior vena cava, also access through the port site into the left subclavian vein. And we did balloon angioplasty. You can see that there's a waist right here that indicates that there's a stenosis in that vein. And then with mechanical thrombolysis post-procedure, The thrombus is gone in the right subclavian vein. There's now patency of the right brachiocephalic vein as well. You can see that there's persistent narrowing of the superior vena cava at this level. And the catheter tip, remember, was really high. It was very high in the SVC. We weren't able to open up the left brachiocephalic vein all the way, but the lumen that is patent was the size of the catheter that was in place. But you can see that there's now flow to the superior vena cava. Here's another example of a malpositioned line. You can tell that this was pulled back. The catheter tip is high in the superior vena cava, and on the CT you can see that it's abutting the right lateral wall of the superior vena cava. There's thrombus around the distal catheter extending into the left brachiocephalic vein, and then it also extends into the left internal jugular vein. And here's the catheter tip. After the port was removed, this was an oncology patient, there was bleeding into the chest wall, but there was a repeat CT to look at the anatomy. And you can see the thrombus in the left brachiocephalic vein extending into the SVC, abutting the right lateral wall right along the course of the prior catheter. And then it went into the internal jugular vein. So on this patient, we did venography 7 days after the catheter was removed. And it shows occlusive thrombus, like we saw in the CT, in the left brachiocephalic vein. There's no opacification of the SVC, just numerous collaterals in the mediastinum and neck. And we did mechanical thrombolysis, and we were able to reestablish patency of the left brachiocephalic vein. So you see a nice open brachiocephalic vein. There is a stenosis at the junction of the internal jugular vein and the subclavian vein, though. And I know we did balloon angioplasty on this one too. Here's an example of a malpositioned central venous catheter. So this was immediately post-placement, and there's a right pneumothorax, which is one of the complications. So they tried for a line on the right. So typically it's a subclavian attempt when you see a pneumothorax, but you can get a pneumothorax with an internal jugular access as well. So that's why real-time ultrasound helps you to get into the vein perfectly and reduces the risk of pneumothorax. And then 8 days post-placement, the pneumothorax is resolved, but you see the catheter tip is short. It is in the upper SVC. This line was not functioning. 1 year later, there was abrupt swelling of the left upper extremity. We did right upper and left upper venography. And what you see is that the right brachiocephalic vein is occluded. You have collaterals from the right subclavian into paraspinal vessels, which then go to the azygos. And in the left upper extremity, there's acute thrombus in the left brachiocephalic vein with numerous collaterals around the heart. The kiddo had the port removed. There is a CT, and on the coronal images, you can see a stenosis, and after mechanical thrombolysis too, but you see a stenosis at the junction of left brachiocephalic vein and superior vena cava, which is pretty tight. We did angioplasty, so here's the left upper extremity venogram prior to angioplasty, and you see a really thin jet of contrast to the stenosis. Balloon angioplasty, and then post-procedure, the stenosis is definitely more open, and there is free egress of contrast through that stenosis into the SVC. And you can see some contrast in the wall of the vein as well. When you're doing angioplasty, you're injuring the endothelium. You're injuring the vein wall. So it's not unusual to see contrast extending into the vein wall. So in conclusion, catheter tips that are high in position or short have many more complications than well-positioned lines or even deep lines. And the complications include thrombus formation, fibrin sheath, blood clot, and then permanent venous occlusion. A short left upper extremity line has more complications than a short right upper extremity line. And subclavian vein access has more complications than internal jugular venous access. And again, I really think we should be doing surveillance chest x-rays on kids that have long-term lines, so those with ports and Broviacs. Should probably be annual to double check tip position, but in kids that have growth spurts, so in infants, toddlers, et cetera, whenever there's growth, we should look at the tip position. If it's high, we really need to change those lines if they still need their vascular access to reduce the risk of complications. Thank you. So what questions are there?
Can you describe any differences that you think might be present between a Broviac or a port placed by IR and placed by surgeons?
I think it's individual. We don't use subclavian vein. We always use internal jugular, but you can also do ports or Broviacs in the arm. So you could do brachial or basilic vein too.
In terms of, you both use the same fluoroscopy.
Well, we're doing ours in the IR suite. We all have fluoro, yes. And then I think the surgeons could speak as to whether they use ultrasound or not. Well, it's related to catheter tip position and insertion. So I showed some research on that. So it's different by research projects. But it's high when the catheter tip is high in position. The complication rate is much higher. We had up to 58% in one study. But also, we know that if you do subclavian access for HD lines in children, that those kids have a much higher rate of stenosis. So over 80% have had reported stenosis in this one study with the dokey guidelines, which is the National Kidney Foundation.
Carrie, when I was going to retire about 9 years ago, they were talking about vancomycin impregnated catheters as infection. Anything about what the stance is?
You know, they do have catheters actually antibiotic embedded, but also to reduce the risk of thrombus. And I think the jury's still out on how effective those are, because I don't know how long the antibiotic is actually in the catheter. So they're using those sometimes in kids that are immune compromised, but it's on a case-by-case basis. I'd say the majority of people are not using those. Ian? Yeah, there hasn't been a research study on that. However, when we're placing lines from below, we want the tip to be just below, we're typically at the level of the diaphragm. So we think the IVC is still entering the right atrium above the diaphragm, but it has a nice straight vertical course. So we're going for diaphragm placed from below, so in the IVC. In little ones, when the hip is flexed, the catheter can migrate higher. So typically when we're placing the line, we'll flex the hip to see the highest point of the catheter to get it at the diaphragm. So as long as it has a nice vertical course, the risk of complications, just like for SVC, should be lower. Diana?
So one of the things that we see in radiology elsewhere in CT and MR is we want to power inject lines. So what are the guidelines for choosing when to place a power pick and a not power pick?
What we're doing is in the venous access order, there's an indication of what's going to be infusing through the line. Also, if you have a child that's going to need CT examinations, then we would place a power pick because we can inject contrast through those lines. The other thing is for some of the cardiac cases, depending upon what it is, when we first place a line, we will place it higher in the right atrium to allow for the CTA, the cardiac CT, and then we'll pull the line back a little bit to the diaphragm, and it just allows for better imaging for cardiac CT. But a power pick should be chosen, one, when you need to do repeat CTs or even think you're going to do a repeat CT. Any other questions? Oops, sorry, John.
Do we have any program in this institution, and it's not, do you know about other institutions as far as, surveillance for these lines? Because, I mean, looking at all those pictures, it does look like there's probably one area where we have great room for
Right, I agree. So I think we need to talk to, it's primarily oncology patients for the long-term lines. However, for in-house, when lines are pulled back, it's really important for everyone to realize that if the line's pulled back, you need to repeat imaging to see where that catheter tip is. Because if you still need that venous access for a while, it needs to be replaced. You need to get an ideal position because the complications are so much higher when it's short.
Yeah, but further things on, I think the GI patients too, the little babies
Yeah, anyone who's, yep,
that have short guts, I mean, they grow a lot.
anyone with a chronic line, yep.
Yeah. And then the other question was, can you talk a little bit, let's say there's a line that's not perfectly positioned, but you only need it for like 2 or 3 more days. How many of these complications are you going to get within just less than a week versus longer term?
I don't have that number. But typically I would say if you only need the line for 2 or 3 more days, you're most likely okay, depending upon where it is. So I think it's a case-by-case basis. And what's infusing through the line too.
Is there anything that would be super high risk where you would say, hey, even 2 or 3 more days, I wouldn't want this to happen? Where would they have to?
I think if it's in the upper SVC, you worry, and brachiocephalic. Yes.
That was very nice.
Thank you.
That was good, and I really appreciate the comments about venous conservation, which are so important. Could you comment a little bit about doing thrombolytics and how successful you are? And I mean, you guys say, oh, this line's been plotted for a week or 2 weeks, we can't do it. Are we not doing thrombolysis enough, you think?
They're doing TPA and catheters that are occluded. When it comes to thrombus formation, one consideration is if you have flow to the site, you can do systemic TPA. Lovenox itself has a thrombolytic component to it as well. But thrombolysis is effective, and we're doing it like for DVTs for other things as well, but we've done it for lines as well, and you saw examples of that. So it is very effective. So, and you can do sharp recanalization too, even with chronic thrombus, potentially, to get access restored. Rich?
Things have changed over the last few years, more so than many years before, and so it's very difficult to predict if the clot is soft and lysable chemically or not. Now we have added to that grouping mechanical devices. There's several that could work on more fibrotic or older clots. So we think that big vessels are really important to keep open because, as you know, it's at times a life-saving decision for transplantation, for chemotherapy, for all kinds of stuff. So our level of interest in being more aggressive has grown because we've seen the sadness of not having a candidate for a life-saving procedure with no access, and that takes them off list, cardiac transplant, liver, and so on. So we would rather err on the side of being more aggressive. But the biggest thing is venous conservation from the end. Now, from the beginning, I mean, and so we don't do cut downs very much anymore. But in the old days, it's a huge source of loss of vessels. We see it with ECMO. Again, I'm not being critical of it. It is what it is. So not using the subclavian, I know that's it's fighting words at some level, but if you don't use the subclavian, it's better. So that's our mantra. So we stick to it because we really believe that's the critical decision.
Any other questions? Thank you, everyone. Have a good day.